Welcome everyone to today's webinar, Surprise Billing Legislation, Overview, Response, and Future Implications. I am Ayla with Becker's Hospital Review. We will begin today's webinar with a presentation, and we will have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Mark Eisenberg is an Executive Vice President of Healthcare Advocacy with Zotec Partners. Mark joined Zotec in 2001. Currently, he works with healthcare organizations and lobbyists to advocate on behalf of Zotec's clients and physicians at large on matters related to public policy and healthcare legislation. Mark's experience as a seasoned revenue cycle management professional, as well as his past experience as special assistant to former Indianapolis Mayor Stephen Goldsmith, gives him insight to better assist organizations in charting congressional and regulatory strategies. Mark graduated from Georgetown University with a Bachelor of Science degree. He's a member of the Radiology Business Management Association and serves on its Federal Affairs Committee. Thomas Harold serves as Senior Vice President of Radiology with Zotec Partners, an industry-leading provider of hospital-based revenue cycle and practice management services. Tom has worked in the healthcare industry since 1979. He specialized in radiology and radiology billing and oversees radiology client service nationwide for Zotec and its clients. Tom graduated from Vanderbilt University with a BA in Business. He is a member of the Society of Interventional Radiology and serves on the Coding and Economics Committee, as well as serving on the Programs Committee of the Radiology Business Management Association. Tom is a frequent speaker at national radiology meetings and conferences. At this time, I am pleased to turn the floor over to Tom to begin today's presentation.
Thanks, Isla, and we appreciate everybody being here today. First, just a disclaimer that the views expressed here in the webinar are not representative of any specific political party or affiliation and should only be regarded as professional positions and insights from the Zotec Political Action Committee. Our agenda today will be an introduction of the issue, the review of the federal legislations, review of the state legislations, the challenges with the implementations of these legislations, President Trump's executive order, and what can I do to help, as well as the Q&A that Isla mentioned. So with that, I'm going to turn it over to Mark, who will take us through the agenda.
Sure. Thanks, Tom. I appreciate the introduction. So I guess the big question is what are they, both state and federal legislators, trying to address? And the main issue and what they're trying to address is to get patients out of the middle of what is called a surprise bill. And so what does a surprise bill actually mean? Well, there's two components to a surprise bill, or there's two causes of a surprise bill, if you will. One is emergency services. So when you think of emergency services, think place of service 23, as well as all the ancillary service, radiology, pathology, plastics, etc. For an out-of-network facility or for an for an in-network facility with an out-of-network physician. So you go into the ER, you think you're at an in-network facility, the emergency room physician who sees you is out-of-network, and maybe the anesthesiologist is as well. That's issue number one, so emergency services. The second issue that they're also addressing are more of the scheduled services. So you schedule a service in an in-network facility, you go in for a surgical procedure, and the anesthesiologist happens to be out of network with your carrier. That's the second situation that they're trying to have patients avoid. Now, one thing to be clear is that all of the federal bills address both of these issues. The reason that I'm discussing them separately is because the state bills get a little bit challenging in their interpretation of them. Some of them only address emergency services, and some of them have different payment rates associated for which type of service it is. Medicare real quick. So I guess the big question and what everyone really wants to know is, will this impact my profitability? So that depends. And I know that that's kind of a cop-out answer, but whatever your structure or your group's current contracting philosophy is would impact this. Do you have an out-of-network philosophy? How many carriers are you out-of-network with? Do you balance bill the patient? If you do, then the likelihood of this bill impacting you is greater than if you don't. The other question is what are the minimum benefit standards in your states? So each state legislation has a minimum benefit standard, and what I mean by that is what are they going to pay? So these laws are designed so that the carrier pays you, physician group, or the hospital directly, and in return, you are just supposed to take the cost sharing, the deductible, the copay, et cetera, from the EOB. You are not allowed to balance bill the patient any difference. So depending on what that initial minimum benefit standard is, will determine in your state where you may have a financial impact with regards to that. One other thing is the negotiation with the carriers post-passage, and this just doesn't affect out-of-network philosophies. This could also be in-network. And what I mean by that is what we've seen is in states that have passed legislation and it's been in effect, say for 2017 out in California, we are seeing that since the minimum benefit standard for out-of-network is 125% of Medicare, we're seeing the carriers out there actually cancel contracts that exceed that amount currently. So depending on where your contracts are, you may think, hey, I'm at 140% contracted with all the carriers in California. I don't have anything to worry about. Well, because they put a threshold on what the out-of-network compensation can be, you are at risk for that compensation. And we have seen it in the RAND study. RAND Corp did a study just recently released that's been getting a lot of publicity, indicating and pointing out to the challenges associated with California. Another issue is what is your relationship or contract status with the hospital? We have seen hospitals lately trying to force contractually to have their hospital-based groups or physicians that service the hospital actually be in network with everyone they're in network with. And we've also seen legislation that has thought about forcing that issue. Well, of course, if that's the case and the issue is forced, then the carriers know that, and therefore they can be a little, they have the upper hand in terms of negotiating power with you when you're trying to negotiate those contracts. And then those are the potential revenue hits that you have at stake. But then there's also costs associated with this. So in all of these provisions, they have, generally speaking, have IDR, which is independent dispute resolution, or arbitration clauses in them, which give the provider the opportunity to challenge a carrier's payment to them. And so in that situation, you obviously have the cost association with that process. But anything else that you might gain from them comes at a cost, and also with the time value of money as well. Anything that you recoup as a result of that arbitration would be slower coming in the door as well. You also have database costs. And what I mean by that is the minimum benefit standard is based on generally 3 different databases of information. So it could be a carrier-specific database. So in other words, they say 125% of the median in-network rate. You are relying on the carrier's database in order to come up with what that number is. There are also states that have all commercial or all carrier payer databases. Colorado in particular has one, and they utilize that in their out-of-network legislation. But these databases, and including Fair Health, which is another one that is used in quite a few states, these databases, to some extent, except for the carriers, have costs associated with them. I've heard from Colorado that their all-state claims database is roughly about $20,000. So if you want to have access to that database to verify that they're paying at the rate that they should be paying, you'll have to pay to get that access. And then, of course, there's also implementation costs. So when you're thinking about implementation costs, you have legal opinions, you have potential changes to statements that you're sending out to patients. And then you have implementation of notification and transparency requirements. So all of these bills, generally speaking, have some form of notification to the patient, and they also have transparency in terms of essentially listing on websites which carriers you're in network with. And in some cases, they actually force to give you an estimate of what that out-of-pocket expense might be. So as you can see, we may not get, the quote-unquote Medicare for all, but if we aren't real careful, we may end up with Medicare allowable for all, because this is kind of driving the commercial rate structure down more in lines with what we're used to seeing with Medicare. I will tell you that if this is one of the more hotly contested and lobbied events in the last probably 2 years that I've been a part of. In fact, if you land at Washington National Airport and you're heading down to pick up your bags or to get a cab, on the escalator on the way down there, there is a video sign, and that video sign has been running a UHC commercial about surprise billing. So every time a legislator lands and comes through National Airport, they're reminded of this issue. So it is front and center of everyone out in Washington, D.C.
Yeah, to reiterate Mark's point as well, the EDPMA reported recently that there was a Georgia contract canceled with a demand of a 25% rate reduction because they expect the rate to be set where the rate is at the time of legislative implementation. So there is bad acting on the part of a lot of carriers looking to make this a great opportunity for them.
So let's move on now and talk about the review of the federal legislation. So as of right now, there are currently 8. I'm going to briefly touch on the first 4. The first one was Representative Doggett's bill out of Texas. Bill has been introduced. He's been involved in this discussion for quite some time now. The other bill is from Senator Shaheen. The third bill is from Senator Scott. And then the fourth bill is from Senator Kennedy out of Louisiana. Now, I'm not going to spend a whole lot of time on those bills just because they've been introduced, they've been discussed, but they don't appear to be the vehicle of passage or a vehicle to a full vote regarding the federal legislation. So I throw those out there just to let you guys know that they do exist, that we are aware of them, we are tracking them, but in terms of the traction that they're receiving, it's very nominal up until this point. I do want to focus on the last 4, but before I do that, I also want to tell you that I've heard of a 9th that's coming out from Representative Brady, who's the president of the House Ways and Means Committee. So that's a very powerful committee, and so it'd be interesting to see what he's coming out with, but I've heard that is in the works, so maybe when they get back in session, that will be introduced and we'll have a chance to talk about it. So let's talk about the Senate side of the equation first. So Senator Cassidy and Senator Bennet spent months working on their bill, STOP, as it's referred to. And over that course of the month, we've had many conversations with all of their legislative aides. They've had conversations with the carriers, all of the specialty societies. The staffers are very knowledgeable on this legislation. They've put together what seemed to be a very palatable resolution to this issue. And at the end of the day, it was instructed that instead of having this bill pass individually, what was going to happen was that Senator Alexander out of the Health Committee, with his lower health care costs, were going to include essentially this issue in their overall more comprehensive bill designed to really reduce cost of health care across, and it's just not price billing, but also, for example, drug pricing. So that lower health care costs, if you focus on Title I of that is where they address the surprise billing aspect of it. So that's why I kind of paired these two together, because it's essentially morphed into one that will be coming out of the Senate for a full vote. So what does this bill currently look like? There was a markup of this bill in the committee on June 26th. What it does is it does cover both types of surprise billing, both the emergency services as well as the scheduled services. This legislation would ban balance billing for out-of-network emergency care and require plans to reimburse those providers at the plan's median in-network rate. Unless IDR is included, which it currently isn't, Title I could lead to narrower networks, jeopardize the patient's access to emergency care, destroy the market forces that allow for fair negotiated rates, and give the insurance industry a huge edge in contract negotiations. So this bill actually was, with the arbitration provision in it, this bill without the arbitration provision in it went to the CBO for a score. CBO came back and estimated that there were a potential $7 to $8 billion in savings should they adapt this legislation over 10 years. And in that bill and in those discussions, Senator Lamar Alexander has been very vocal about identifying community health centers or federally qualified health clinics to kind of redirect that money. So essentially what he's saying is I'm not taking money away from healthcare. I'm essentially slashing that cost and reinvesting it into these facilities, which is great. They need the additive cost, but they don't need the additive, or they need the additive money, but they don't need it at the cost of the physicians out there providing the services. But this is a very big deal to Alexander in terms of being able to redirect this money. So what's next for the Senate bill? Senator, on the 26th, the Health Committee did in fact vote to move this bill out of committee. There were 20 yeses and 3 noes. The noes were Senators Paul, Sanders, and Warren. Cassidy was able to get his amendment number 3 added to the bill, which establishes prompt pay and network adequacy requirements. Both Cassidy, Hassan, Murkowski, and Romney all said that IDR needed to be part of the benchmarking. Cassidy said benchmarking without IDR would put all the power in the hands of the carriers and it will be a race to the bottom. Chairman Alexander said at least twice that he would work with Senator Cassidy and Hassan to further improve the bill. We believe that there's little appetite for a full Senate vote without some IDR provision in there with meaning. Last I heard from a Republican healthcare legislative aide, there were still 17 bipartisan holds on this vote, so they go out and see if they were going to move it to a full vote. What's the likelihood of passage? I've heard that the number is anything greater than 10. They'll put a hold on it until they can reach some resolution in order to get that number down. I do know that Senator Cassidy continues to run point on this issue, so they are trying to work on some type of meaningful IDR provision in this bill. I was also told that by the same legislative aide that when they get back from session, they're going to shift more to budget issues. So DISH, Medicare, Medicaid extenders. She suspects that this will drive the legislation agenda after their recess. Surprise billing is important, but there are still a lot of obstacles to overcome to have an imminent vote at this point in the Senate. If IDR is added, though, I will say this, and CBO scores it, and that scoring diminishes the potential savings that Alexander is looking for, we may have another stalemate as well, depending on what CBO comes back with. One thing to note, too, that I don't know if you watched the first Democratic presidential debate, but in some targeted Senate areas, there is a group known as Doctor-Patient Unity, which no one seems to know where they're coming from, but they have spent about $2.3 million in ad campaigns for vulnerable senators in tight races advocating on not passing this bill. Now, of course, that pales in comparison to the Coalition Against Surprise Medical Billing, which is a group publicly funded by Blue Cross Blue Shield Association and America's Health Insurance Plans, who are actively negotiating, obviously, the passage of it with no IDR provisions in place for that. So now let's move on to the House bill. So on the House bill side of the equation, the important thing to know in how this kind of transpired was Ruiz and Rowe, both physicians, obviously have a lot of skin in the game, not only with their constituency, but knowledge with how to address this issue. They worked diligently in putting together a bill that they thought would solve the problem. In fact, most specialty associations, the ASA, I think EDPMA, have all reached out and said that they were supportive of that bill. However, Pallone he's the chair of of this committee, and he himself wanted to put together a bill and bring that one to a vote. So he did not bring the Ruiz-Roe bill to a vote and instead proposed his own bill. The No Surprise Act, essentially, the patient, an emergency service, the patient is only required to pay the cost-sharing amount required by their health plan for in-network services, which is calculated either the lesser amount under state law, if applicable, or the median contracted rate. So they focused in on the median contracted rate of the carrier's database. There's no balance billing. Any cost in excess of this amount will be paid by the health plan either in accordance with state law or an amount based on the median in-network amount. This will be adjusted by the Urban Consumer Price Index set for the year 2021, which will be tied to 2019 rates. And that's important to note that it's tied to 2019 rates, because that's why we have seen some activity from the carriers to try to drive down what that median rate is for 2019 by either canceling contracts, especially those that are above what the minimum benefit standard will look like, but they are, in essence, trying to make sure that that benchmark is as low as possible if this law were to pass. There's no balance billing for non-emergency services. However, if informed consent is not documented and retained, documentation requirements have not yet been established or identified for that. There was an IDR amendment that was added at the last minute that would allow for IDR for any claim that the allowed amount is greater than $1,250. So that essentially means, let's just take the hospital business, because that's primarily where the attention has been focused, on roughly less than 4 to 5% of overall volume that would be subject to arbitration, because that threshold of $1,250 for allowed per claim will never be subject to that or allowed the protection of that arbitration. Interestingly enough, this bill does not currently apply for ERISA plans or self-funded plans. And that's the real reason kind of why the federal government has decided, or why they are jumping into the fray, if you will. And we'll talk a little bit more about this when we talk about state legislation. But the Department of Labor federally governs all self-funded plans across the nation. So in many states that have this surprise billing passed, they don't cover ERISA or self-funded plans. Now, some allow them to opt in, and again, we'll talk about that a little later, but that was the true meaning and reason why the federal government was acting to try to pass these laws, was because, and roughly 50% of the commercial plans out there being self-funded were not actually covered by the states who in fact passed those laws. So it'll be interesting to see what happens if that continues. So what's next for the House bill? As mentioned, the IDR was passed by the House Energy and Commerce Committee in mid-July, but there's that highly problematic threshold for the IDR provision. Again, in my discussions with the legislative aides in Washington, D.C., the IDR threshold that Pallone was willing to accept was originally $1,500, but Representatives Ruiz, Roe, and Bouchon were able to get it down to $1,250. They wanted IDR included and are looking for the Senate to normalize. Once they added back in that provision, interestingly enough, AHIP and the ERISA supporters essentially pulled their support for that legislation, which they had previously given it that support. It is believed that this IDR amendment is being scored by OMB as well, but depending on the results and the methodology used, that could influence next steps as well. So we have not yet heard back from what their proposed scoring would be. This bill is likely to be voted on when the House resumes from recess. So this bill, I do think, unlike the Senate bill, will see a vote. I do think that, however, if it should pass the House, that it will go back to my earlier comments with regards to the Senate, that the Senate will want to have some meaningful discussions and provisions added in terms of independent dispute resolution, a fair minimum benefits standard, as well as as well as any potential arbitration associated with that IDR and what that will mean. So a review of state legislations. This is where it gets interesting. So there are 5 states currently this year who have passed out-of-network legislation in 2019. Approximately 25 states in addition to those have existing legislation. States that everyone probably knows are more fluid and looking to pass legislation prior to the federal legislation. So if you are a state that has passed legislation, your state law trumps the federal law in terms of this. Now, again, the question becomes the ERISA plans or the self-funded plans, but the states are rushing to try to pass these legislations prior to the federal because they want their legislation to rule the state versus the federals. If you do not have one in place and the federal does pass it, that federal legislation would govern everything, including those ERISA plans that we were discussing earlier. What's interesting to note, too, is many of the states, it's gotten a little bit better in the last couple of years, but the majority of states out there have what we call a supermajority, and what that means is that they control the governor's mansion and they control both the House and the Senate of that state. So either all Republican or all Democrat. And so you can see that eliminates a lot of the friction in passing these legislations. So they've been introduced and been passed very quickly. So they're very challenging to kind of keep track of, and there are a lot of last-minute negotiations that don't give you a lot of time to really lobby against. Let me go back one, I'm sorry. So the bills differ greatly. And what I mean by that is they have a variety of different arbitration or independent dispute resolution timelines. Their minimum benefit standard is based on different databases. We talked about them earlier, the Fair Health, the carrier database, or the state all payers database. Some have statement language changes in it, so that meaning that you have to give notice in statements that are physically mailed to patients and or emailed or text to patients. They have to contain certain language. Most of them have notification requirements, and those notification requirements could be against the insurers, for the facility, and or for the physician. So in some cases, all 3 of them. So it's very challenging to understand what those notification requirements are. You also have transparency requirements, meaning the pricing of certain procedures and or who you're in network with. Some state laws, like New Jersey and Texas, allow for ERISA or self-funded plans to opt in to this protection. So that's just a sampling of how some of these bills differ. Now, the challenges with implementation. This is where it gets very interesting and very confusing all at the same time. So the first question is it an ERISA plan or not? And then the second part of that is, if it's an ERISA plan, are we to use the state that allowed it to opt in or the federal law that could potentially be in place? As most of us know here, the carriers do not identify the type of plan in their remittance files. It's generally just, here's the plan, here's the code, here's what we're paying, but they don't identify if it's a self-funded plan or not. So we have had in every conversation with elected officials, it's going to be incumbent upon the carriers to allow us to know which law we need to follow based on what that plan represents. So that is a challenge that no one seems to have an answer to just yet as to how that will work out. Also, these are extremely poorly written laws, and what I mean by that is everyone is in a rush to get the political credit for it and let the details come after. The challenge is once they're passed, you have a finite amount of time in order to comply with those laws, and oftentimes we're seeing various state agencies not live up to their end to provide statement language, to provide notification requirements, provide the arbitration process. So it's very challenging. For example, we're still waiting for Texas and the Department of Insurance to give additional information on what we need to include on the statements on a go-forward basis. Colorado, and their recently passed legislation, is involving 3 state agencies: the Insurance Commissioner, the State Board of Health, and the Director of Division, Professions, and Occupation for notification requirements that are needed for us to be able to publicly comply with them on websites for notification and transparency requirements. So that remains a big problem. They'll pass it, they kick it down the road to the agencies, let them figure it out, but these agencies then realize it's not as easy as the legislators had wanted it to be, and it delays, and so therefore with the implementation, you're pretty much flying blind when you're supposed to be implementing it. Obviously, you need to do the best that you can with the information that you have, but it has become a challenge in states that have passed this legislation. There's also challenges complying with notification and consent requirements. Are they website only? Are they on the statements? And then that language that you need to provide. Oftentimes, they'll just tell you kind of generally what needs to be said. So then we bring in a state attorney there to help us out with defining what that is. Then this is interesting too, because does this cover the first issue, which is the emergency services, or does it cover the surprise billing scheduled type of surprise billing? Just to give you an idea, Nevada just recently passed a law that only covers the emergency services. So if you did go to a in-network facility and the anesthesiologist was out of network, that this current legislation does not preclude you from balance billing the patient. So it only addressed one of those issues. So again, it's very challenging to implement given the fact that that would likely be based on a place of service, for example. Another interesting thing is they've introduced scaled payments. So as I briefly mentioned at the beginning of the hour, we talked about California and what we're seeing out there in terms of the cancellation of contracts. In Nevada, they were watching that closely and actually have created penalties for depending on who cancels and if they cancel with or without cause. So, for example, if a carrier cancels a contract without cause for a provider, then that provider is entitled to 108% of what their allowed amount was. So essentially an 8% kicker from that. So we're seeing states that are monitoring other states and improving their laws as they're passing them, which kind of will create all the chaos. For example, Texas had one in place. They've changed theirs to be a little bit better in terms of being able to practically follow that legislation. In other cases, you have Colorado that pays 105% of the median in-network for emergency services. So for the first issue that we're trying to discuss in surprise billing, but 110% for the scheduled part of it. So they are giving an additional bump at 110% of the median for those scheduled services. Additionally, Colorado has this crazy notion of the language is the greater of either the insurance median or the all-payer state database. So they're essentially saying whichever is greater, the median contracted rate in the carrier database or some percentage in the all-payer database of the state. So therefore, you have to have access to both of those in order to know if they're truly paying the greater of. Colorado also has an interesting clause in there that you have a 180-day filing limit from the date of service for out-of-network claims. If you do not file within 180 days, then the carriers are allowed to pay you 125% of Medicare. So just to give you and paint the picture of how convoluted and complex this all can be. One other thing to note, too, is there's the definition of facility. So back on the slide when we were defining the problem, facility in its truest sense was essentially, the hospital. But some states have really expanded that to include ambulatory surgery centers and diagnostic imaging facilities. So again, another challenge with complying with knowing when you should or should not comply with these laws. So I know that this really wasn't the topic, the surprise billing, but President Trump issued an executive order in June 24th of this year, and in that he was very clear that he wanted to have transparency. No one was really quite sure, and he gave a 60-day rulemaking process to have his staff figure out how to do this. we just saw the first iteration of this in the recently proposed ops rule that is out for comment right now with CMS, whereby CMS is essentially mandating hospitals to publicly display their negotiated rates for 70 bundled services on the hospital site. And when I mean contracted rate, I mean carrier allowed amount rates for both the facility as well as the professional component side of the equation, so the total cost associated with that. And then the proposed rule also suggests that up to another 230 bundled services would potentially be mandated as well. Obviously, we will know more after the final rule, but in that proposed rule, penalties do exist for noncompliance. Up to $300 a day is what was commented. Now, I'm not so naive to think that there aren't going to be challenges to this. In fact, CMS was challenged in their phone call as to what gives them the authority to do this. They pointed to a clause in the current ACA law, but I'm fairly certain that there will be lawsuits forthcoming from many different organizations in an attempt to try to block this. So just kind of finishing up, in addition to his executive order, he had in 90 days, he wants the HHS, Labor, and Treasurer to issue rules that would force carriers to tell patients what they will owe out of pocket before a service is rendered. And so all of us in the industry know that that is a very challenging task to get 100% right all the time. So I know carriers have a lot of consternation with this mandate, and they are likely going to try to challenge it as well. But that is a part of his EO as well. And in addition to that, it looks like he's going to also try to address kind of the quality roadmap, extending out the interoperability in an effort to try to get additional savings out of any government industry that spends money on healthcare. So he's expanded it from CMS and the quality side to HHS, Department of Defense, Veteran Affairs, et cetera. So the reason I mention that is hopefully you get a snapshot of where the land is today. You've essentially got states with governors and their houses running to try to fix this problem. You got the U.S. House of Representatives, you've got the U.S. Senate, and now you've got President Trump. All four are running as fast as they can to try to throw legislation out in order to take credit, if you will, for solving this problem. Because unfortunately, it's who wouldn't want to say I stopped you from getting a bill? It sells very well to the public, and the messaging around it is great for the politicians that are supporting it. So, kind of what can you do to help? It doesn't take a lot, to be candid with you, but from my perspective, I would reach out to any specialty society that you belong to and see what they're doing in this area. I can tell you that this isn't we were asleep at the wheel and nothing was being done about this. These discussions have been going on for years, and a lot of specialty societies have kind of come together for the first time in quite a while and joined forces in trying to lobby and to advocate their positioning on these legislations. So please do reach out to your specialty societies, ask how you can help. They are very interested in having experts appear with them and actually lobby and have discussions with elected officials. And that's the other thing is in terms of lobbying, both the House and the Senate are back in district as we speak. And I have found that when they are back in district, they are far more approachable, especially to a voter. So if you do have the time, reach out, invite them out to your operations, walk them through what you do, explain to them the challenges that you foresee with this legislation, but be there for them and let them know and really convey your challenges with everything that is going on right now. And then in addition to that, there are websites, and our Zotec PAC website, that's the front page of it, just to the right there. And obviously ours isn't the only one, but it is one where you can actually sign up and get notifications when things change on these legislations. And what we've done too is we've also now embedded in an advocacy tool that would allow pre-written messages to be automatically delivered to the elected official of So, if you live in Indiana, your representatives and your congressmen and your senators would be identified and would automatically go out to them. So we know that everyone in the healthcare community is very busy, including physicians, from that standpoint. So we wanted to make it as easy as possible to do. But like I said, there are various other websites that you can do that and participate. And then I know if you have the ability to do it, host an event for an elected official, raise money for them. No one really likes to talk about it, but it matters. They want to hear from you independent of you giving money. But if you do give money, it resonates with them, and it does matter. So, if maybe you want to host a fundraiser for a local candidate, or if not, and you're not in a position to donate directly, or you don't want anyone to know that you're donating directly, there are political action committees that are formed that are fighting this issue on behalf of healthcare administration and physicians across the country. So identify those, go out, make a donation, and give them added ammunition to fight the cause. There is a lot of money stacked up against healthcare administrators, hospitals, and physicians on these issues. And then communication. Both quality and quantity matter. Respond and advocate when asked to do so. So when your societies are asking you to advocate, do it. It's important. It matters. They keep checklists of for and against. They give that information to the elected official. He or she is asking for it. So if you're not responding and the other side is, then the likelihood of success goes down dramatically. So with that, I know we didn't have a whole lot of time, and there are a lot of different issues that we could have gotten in the weeds on. I'm happy to open it up for a question and answer session to the extent I might be able to answer it.
Great. Thank you so much, Mark and Tom, for that fantastic presentation. And we will now begin today's question and answer session. So please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we have time for. We've already had several questions come in so far, so I'll go ahead and get started with those. And the first question for you, Mark and Tom, is are New Jersey and Texas the only states that allow for ERISA?
No, I believe that the Washington law that just passed also allows for the ERISAs to opt in, and there are likely others on the 25 that have passed. But again, I think that will be, the states really don't have jurisdiction over ERISA or self-funded plans, so I'm imagining that might get, involved in some type of lawsuit should a federal law pass. Or even if it doesn't, somebody might question the fact as to why the state thinks they have jurisdiction over that.
Great. Thank you so much for the clarification there. And we'll go ahead and jump in with the next question. And this person wants to know, where can I find consent and notification requirements for my state?
It's a good question. It's not easy. First, you need to track down the actual bill that passed, and every state has a free website that would allow you access to those documents, but find out then which department is responsible for creating those, and they likely have a website as well that they may be posted on. And then in addition to that, if you don't want to do any of that legwork, there are a lot of attorneys, healthcare attorneys in those states that would be able to assist you in identifying or tracking down the appropriate agency that has those requirements.
I think the specialty societies can help with that as well, in that they're often engaged and will have that information to assist.
Great, thank you for providing those resources. And I think for the next question, it's something that's already been touched on a bit, but the question is, do you foresee any potential legal actions healthcare organizations might take as a result of these laws?
Yeah, depending on who quote unquote wins and who quote unquote loses, the losers are for sure going to try to question these issues in court. It's very interesting. I mean, you have the federal government who's mandating pricing for commercial rates. You have the federal government and the state governments essentially putting minimum payment standards on what was before, two private entities entering into a contract. So it'll be interesting to see where this all ends up. But yeah, there's definitely going to be lawsuits that obviously likely won't delay any implementation, but it could have challenges down the road should they be successful.
So a lot still up in the air, but definitely lawsuits from one side or another in the future. The next question that we had come in, this person, the question is in reference to the federal legislation. So they want to know, what is your prediction about whether internal dispute resolution or arbitration will be included in the final version of the federal legislation?
I think it's right as it stands right now. I think it's a high probability. That's not to say that we shouldn't stop asking for it and lobbying for it. But had you asked me that question 6 months ago, I'd probably tell you that it wasn't great. But I know that especially some in the House and in the Senate, to a greater degree, are very aware of the need for this, just to keep both sides honest while this process moves forward. Without it, it gives the carriers all the leverage in terms of being able to negotiate with independent and private physician practices.
Yeah, I think unfortunately, as with so many things, politics comes into play. The insurance companies have very, very deep pockets. They are pushing very hard on their side of the legislation, trying to make sure that it is to their financial advantage. The other side, the physician community, is not as well funded, but usually has a pretty good impact, provided that people let their voices be heard. And physicians are unfortunately not as active politically as they could and should be. And if we can get them to be more so, we have a better chance of coming out on the winning side. I think going back to what Mark said too about the lawsuits, we can almost be assured that whichever side is losing is definitely not only going to file, but then try and put other political pressure applied to bear so that they can, in effect, possibly alter the legislation or get it to a more likable place.
Thanks, Mark and Tom. And actually, the next question, it kind of flows from what you were just mentioning, Tom. And this person wants to know how much have insurance companies influenced this push for legislation on out-of-network billing? I know you just touched on that, but anything additional you'd like to add as well?
No, I mean, they're definitely driving it. This has been, if you think about it, and you're a radiologist and a hospital-based physician, your only leverage is to go out of network. And if they can get a ceiling on what they have to pay for that service, it completely changes the landscape of those negotiations. So, again, that's why I wanted to stress earlier that this isn't just a out-of-network issue for people who have that as a strategy, if you will. This is truly independent of specialty. This is allowing the carriers the ability to know what their ultimate downside is. So from that standpoint, they if you threaten to go out of network, they know exactly what they're going to have to pay you. And where in the past, that kind of brought them to the table to be more commercially reasonable in the rates that they were offering. So they're spending a lot of time, effort, and money on it, as referenced by that, the electronic ad that's been running at Reagan National for at least a year, probably longer than that.
Wow, thanks so much for a lot of resources being pushed towards this effort. So it'll be interesting to keep following this as well. The next person that submitted a question, they just wanted clarification about something that was mentioned earlier. And this person asked, did I understand you to say that if state legislation exists, then it trumps anything passed on a federal level?
Yeah, the state law would, but the question becomes, the federal is essentially saying it would the federal law, if passed, would account for and trump the state on ERISA plans or on self-funded plans. So you could essentially have, well, you would have two different out-of-network laws that you needed to comply with. Non-ERISA plans would be governed at the state law, and ERISA and self-funded plans would be governed at a federal law. So again, pointing out the challenge associated with, one, I don't even know if it's an ERISA plan right now, and two, if it is, and that state has an opt-in ability, which one am I following? I guess the other point to that
you can imagine,
like in New Jersey, which is a very punitive out-of-network law, and they allow you to opt in. You know, if the federal government, in fact, does pass something, well, then you're going to have those self-funded ERISA plans opt in with the New Jersey state because it's better for them as well. So that's another challenge with it.
And you can imagine in from an operational perspective of trying to determine whether or not a payer is paying you correctly. By not identifying if it's a ERISA plan or not, then you are looking at it saying it's paid correctly, it's not paid correctly, you appeal it, you find they say it's ERISA, you don't know, you have to take their word for it. It is very, very challenging from an operational perspective. So hopefully there'll be more clarification.
Great, thank you both. The next question has to do with, this person wants to know how are out-of-network providers such as registered nurse, first assistants, licensed surgical assistants, et cetera, expected to fare with this change, given that they don't have alternative revenue streams and that insurance providers haven't negotiated fair rates with them or have closed panels, which don't allow them to be in network.
Yeah, they would be subject to it as well. So it would have an impact on anyone who is submitting a bill to a patient or to a carrier and is out of network is who they are targeting.
Great. So it affects everyone across the board here. We've had several more questions come in, and we'll try to get through a few more before the end of the hour today. And the next question here is, if using a carrier database, is there a provision to verify that the amounts are certified and correct?
Not currently, no. I mean, that's obviously been the challenge with, relying on the carrier database. The Fair Health database is one that was created from a lawsuit out in New York, and it contains a lot of data from all payers, and that's in fact the one that the New York State out-of-network legislation utilizes in terms of coming up with the minimum benefit standard. So yeah, I mean that is the challenge. It's the carrier's database. There's no verification that what is in there is accurate, and it's a black box, if you will, to physicians across the board.
Great, thanks for clarifying that. We have time for a few more questions. And this next person wants to know, if we are in a state that is 70% Medicare and we have a contract that requires us to participate with all the commercial insurers our hospitals contract with, what are we at risk for? Is this just affecting out-of-network billing?
It depends on what the minimum benefit standard is for that state. So you do run the risk. If you are forced to, through your hospital, contract with whoever they're in network from a commercial standpoint, then yes, you're at risk, assuming that your contract right now is higher than what that minimum benefit standard is. Because if it is, they'll come in and, just like they've done in California, they'll figure out a way out of that contract and then force you down to whatever it would be for that out-of-network payment. So again, not knowing what state they're in and what the minimum benefit standard would be and their contractual rates as they stand today, I don't know how big of an impact that would be.
Great. Thank you so much. And we'll go ahead. Looks like we have time for one more question, so we'll go ahead and jump in with one more before we wrap things up today. And this person wants to know just what would you recommend to the providers in terms of contract negotiation for an overall protection from the carriers?
Help fight this, because if not, I mean, they have all the leverage. I mean, I don't mean to be that fatalistic, but that is the reality of it. I mean, it's federal and state governments that are setting ceilings on what you can negotiate with a private commercial payer. And anything that you can do to argue against rate setting and federal involvement and state involvement in what was before that, to commercial entities negotiating in good faith. It's a big deal. Like I said, it's a big deal for people with out-of-network strategies, but it's a big deal for everyone who has contracts with commercial payers, and that's why it's important for everyone to fight against it on our side, but that's why the carriers are throwing a lot of money and resources at it, because they know that as well.
It is a real slippery slope. Once carriers have the ability to influence the government to set rates, for now, it could be just out of network, but at some point, looking at it with success, saying we should set rates on everything. That way we can control everybody's costs and make it a populist idea, trying to sell it to the public. And then all of a sudden, we're in a position where the government has decided everything for everyone. And if you want to see the real success of how that works, you can see how it works in the VA, for example. So it's a very challenging position to be in, and we really need to fight it hard.
I think that's a great note to end on today, a call for action to get involved with this process. And that is all the time that we have for today, but I want to once again thank Mark and Tom for their excellent presentation, and also thank Zotac Partners for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.